Okay. Hello, everyone. First of all, I'd like to thank you for taking the time to join this webinar, especially when many of us have just finished working. My name is Chris. I'm Elsevier's Asia Pacific Product Sales Manager for Clinical Decision Support, and I'll be hosting today's webinar on the cancer patient journey. On today's Zoom session with me, we will have Dr. Ximena Alvira, who will be presenting the cancer patient journey, while Laís Junqueira will discuss how this relates to patient quality and safety. Ximena and Laís, may I ask if you would be able to introduce yourselves before I provide our attendees with a brief background on Elsevier?
Yes, of course. Hello, everyone. Hello over the world. Hello, Chris. Thank you for the introduction. My name is Ximena Alvira. I'm from Colombia, but I'm based in Spain. I'm the clinical and research manager for Elsevier, and this has taken me through this nice journey of sharing research and clinical insights with our community. I'm a medical doctor by background and a doctor in neuroscience. Over to you, Laís.
Thank you, Ximena. I'm Laís. I'm the Quality, Patient Safety, and Innovation Manager at Elsevier, and together with Dr. Ximena Alvira, we're part of the Clinical Best Practice Council at Elsevier, and I'm also part of the Scientific Council of the National Society for Quality and Patient Safety in Brazil. Today I'm dialing in from the Netherlands, so it's a pleasure to make this call even more international. And now I'll hand it over to Chris in Singapore.
Great. Thank you very much, Laís. I'll just change. So a few ground rules before we begin. The webinar is being recorded. The recorded version will be available on our website, and the link will be shared with everyone who's participated on this call. Please type your questions in the Q&A box at the bottom of the screen. We encourage you to share your opinion, and the results will be displayed when the poll is closed. There will be poll questions during this session, and you will see a poll pop up on your screen. Lastly, we appreciate your feedback. Please share any comments via the feedback link that will be shared at the end of the webinar. And I'll just go to the next slide. Just bear with me. So many of you might be familiar with Elsevier, especially through our journals such as The Lancet or Cell, or even our clinical solutions such as Clinical Key and StatDX. What many people do not realize is that Elsevier has been publishing medical journals for over 140 years. Each year we publish over 430,000 articles in around 2,500 journals. And over the last 10 years, we have consolidated all of this medical information into concise and easily accessible online clinical decision support solutions. I'm just going to briefly explain some of our solutions that range across 5 categories before I hand over back to Laís. So first of all, we have reference and decision support solutions. Now, these solutions consist of online databases that clinicians use to obtain evidence-based information to support their diagnosis, ultimately increasing their speed, accuracy, and confidence when diagnosing complex cases. You can see that there's many doctors on this call, and I assume accuracy, confidence, diagnosing complex cases is all something that you're all too familiar with. Clinical practice solutions. A great example of our clinical practice solutions would be our evidence-based order sets, which are continually updated and supported by the latest content. These order sets are integrated into an electronic medical record and can easily be customized to match hospital or even local standards. We also have learning and development solutions that facilitate online education of different medical professionals, radiologists, pathologists, medical students. And second from the bottom, we have patient engagement products. Now, under patient engagement, we've got a great example would be patient education content. So we have interactive patient education content covering over 4,900 conditions. And last but not least, very relevant today, we also have solutions which provide patient-specific care recommendations under pathways. The clinical path is a perfect example, and it provides evidence-based clinical pathways for the treatment of different cancers. Now, that's enough from me. I will hand over to Laís now, who will describe quality and patient safety as it relates to the patient cancer journey.
Thank you very much, Chris. And before we dive into the patient journey, I would like to take the next 10 minutes or so to share a couple of thoughts specifically on quality and patient safety and oncology. And nowadays, it really is safe to say that everyone's lives in our society will be touched by cancer at some point. If not personally, then by a family member or a friend, a colleague. And for most of these people, cancer will be on that pocket in life of very rare events that they have to really put some effort on, but it's still a special occasion that they have to deal with in a certain amount of time. Well, not for this audience and not for the audience we usually work with. Actually, for this audience, cancer is part of their daily routines, of your daily routines, and it's embedded into your day-to-day life, which doesn't make it any less special. Actually, it only increases the complexity as number of cases, situation, actions, and patient cases grows exponentially. And with that growth, we know by numerous articles that we have, one of those you can see on your screen right now, that healthcare per se is very complex. Now, add to that complexity the fact that cancer patients are a particularly vulnerable population within that healthcare system. So any error, for example, can be potentially harmful for a population whose health is already very much compromised. So this high level of complexity, the frequency, and the interactivity of the care processes across the journey really calls for a system that can connect people, process, knowledge, and technology within that healthcare system. So to make that system that is very complex, a little bit less complex, we partnered with the National Society for Quality of Care and Patient Safety in Brazil, and we broke it down into 6 main buckets of attention, which together form the quality and patient safety journey. So on your screen right now, you can see the 6 main pillars that comprise the safe system for the health provider perspective. Starting off with community engagement and health literacy. That is, in addition to communicating, we are also addressing the very ability of patients to understand the health information that is given to them. For instance, smoke cessation. Why is it so important? What are the consequences? So understanding all these basic elements. Once we leave that first community health environment and we jump straight into the hospital healthcare environment, we are faced with a wealth of information to manage, from government policies, hospital policies, for example, for patient admission. Last week, we had a great panel, and Dr. Valerie Young, she mentioned from the National Care Center in Singapore, National Cancer Center in Singapore. She mentioned, for example, the policy on PPE because of the COVID-19 pandemic. So, by the way, if you missed that webinar by any chance, there is a recording available and we'll be happy to share with you. I really recommend you to watch that webinar as well. It was great. We had 2 very experienced clinicians sharing the COVID-19 and cancer journey, what's happening with patients right now. So going back to the journey in a nutshell, the information management part is really about the information that comprises the system and how we can make that information make the system work as an integrated stance. So we have the basis of knowledge, we have the information and the adherence. We move on to the care zone, which comprises 3 pillars: the education and skills of healthcare professionals. For instance, how do we keep up with the knowledge, especially such a complex area such as oncology? Professionals always need to be at their sharpest, which brings us to the next pillar, the care of patients, as you can see on the screen. With process and knowledge working together to support decision-making. In simple terms, for example, checking a clinical practice guideline as you provide care to a patient. And that brings us to the next pillar, right? The patient participation. It's the shared decision making. More than just educating the patients, how can we make knowledge and technology work together to make that experience better? To make sure that the professionals that are also engaging with that patient can also have the tools that they need to do that. And last but definitely not least, we have the research and continuous improvement. And this pillar is all about active opportunities for improvement and practice-based evidence that rises from the day-to-day activities. So producing the evidence, improving at every opportunity that is shown within the other pillars of that journey. As you can see on the screen, each pillar has their own set of key components. However, there's a very easy way to identify trends here. And the trends are back to what we were discussing. It's about people, process, and technology. So let's bring it closer to home, right? Let's bring it to a lung cancer example. How would that play out? So in community engagement, we would have, for instance, general guidance on smoking cessation and lung cancer awareness for the community. In information management, just to mention two examples, we could have the policy of the hospital for admission of that patient, and also, for instance, the outpatient history or the referral information. On staff education and skills, we would have the competencies and skills needed for a timely diagnosis. And we can use as an example, dedicated time for continuing education through new journal articles that are read, books that are read, attending panels of discussion, for example, like the one we had last week, and discussing cases. And in care of patients, we really dive deeper into the specific patient case. For example, what are the diagnostic tests needed for the patient? How about the interpretation of the tests? And what is the treatment recommended for that particular patient? Which again leads us to patient participation. What kind of information do they need to know to be part of the process? Are they undergoing chemotherapy, for example? What are the deterioration signs that they have to watch out for during the session? Are they undergoing surgery? What do they need to know before signing an informed consent form? And finally, we reach the research and continuous improvement pillar. How can we learn from the care we provided? And that was made very clear during the COVID-19 pandemic. Again, to mention last week's webinar, we saw 2 articles that were published based on the practice that had to be done in hospitals. So how do we make sure that we keep that wheel turning, making evidence-based practice and also practice-based evidence to make sure that the loop of continuous improvement keeps on moving? Now, before we dive deep into the patient journey, I would like to hear from you which pillars of the quality and patient safety journey, in your opinion, are really strong at your hospital. So what would you say are the pillars that you really do well? And you can see a poll on your screen right now, and we'll give you 30 seconds so we can give everyone a chance to respond to that. The results are coming in. We still have around 15 seconds. So if you haven't voted yet, I kindly ask you to cast your vote. While you are in the process of voting, I would like to introduce our next speaker. I have the honor and the privilege to introduce Dr. Ximena Alvira, doctor, researcher, and a great friend. And she will take you on a journey of a patient case that is a deeper dive into 3 pillars that we just saw: staff education and skills, care of patients, and patient participation, showing how technology and knowledge can really improve that system, ultimately improving quality of care and patient safety. Dr. Ximena, the floor is all yours.
Thank you. Laís, it's been a pleasure to hear you go over the sixth improved version, the version 2.0 of the quality and patient safety journey. It's a real step up from version or edition 1. Fantastic to see how it adapts to the current scenario, healthcare scenario. So really honored to be following your steps here. Okay, let's review the results. Is everyone able to see the results, Jade? I'm not sure, or Natasha, but
I should be able to see. Yeah.
Great. So care of patients is something that is doing it's great to see that every pillar is receiving attention. Of course, I think this is a reflection of how things are working in general. And thank you. So it's great for you also to see which ones should be strengthened, because after all, this is a journey and every single step requires attention and dedicated attention. So let's continue through this journey that that Laís was mentioning. So this is a journey of a perfect scenario. Of course, this is not a true case, but it's a perfect scenario of how technology, information, and of course, dedication and purpose of improving healthcare come joined together and working in perfect sync to improve outcomes and improve the whole patient experience and patient journey. Sometimes we are not able to improve an outcome. Sometimes mortality or death is inevitable. But what is not inevitable is the whole process until that happens. And we can certainly support our patients and our clinical community to provide the best experience possible. So this is Mrs. Anna Chang, and she's a 65-year-old Malaysian Chinese woman. She has had some cough for the last 2 months, dry cough, no sputum. It's a little bit boring because it tires her, and she has also lost some weight, which she refers to the constant coughing. Nothing to be alarmed, but she nevertheless goes to her primary care physician, who gives her anti-cough medication and with some recommendations. But 4 weeks into the treatment, she's still coughing. She's not improving. In fact, it's increasing. It's waking her up at night, and now she's having some back pain, which she also thinks is due to the persistent cough. So there's no remarkable past medical history. She's a non-smoker, but she has a relative, second-degree relative who had lung cancer. So this generates a little bit of alarm to her primary care physician, to Dr. Lee, who decides to refer Anna to the chest specialist or pulmonologist, or how you call it in your own countries. But of course, she decides to see a specialist to take a little bit higher in the scale of care those symptoms and signs Anna is presenting. The doctor requests a plain X-ray, chest X-ray, and some blood and sputum samples to conduct some tests. So the X-ray comes in, and the radiology office, and the radiologist is a resident who's just starting in his journey through the residency career. It's late at night. He's catching up with some work. He decides to see the X-ray, and he does see an image that calls his attention, which is a small image in the right retrocardiac region inferior to the dome of the diaphragm. And because he's not that experienced and he's lacking all those years, he doesn't have all those years of experience still, and doesn't have anyone next to him to talk, he decides to go into StudyX, a clinical decision support tool for radiologists, to see if there's any information that could support his diagnosis. So he goes into StudyX, types right cardiac mass, and filters by images and by chest to narrow down a little bit the results, and browses the images in the solution that are shown. And he sees one that resembles what he has seen in Anna's in Anna's X-ray. And what happens next is that he clicks on the hyperlink of missed lung cancer. So he's able to read furthermore on the information that is contained within the solution, which has a lot of information, as you might be able to explore sooner or later, hopefully. Key facts, terminology, imaging, and within imaging, he reads something very interesting, that there are some images that are missed an opportunity for early diagnosis of lung cancer. It's one of those situations that generates the highest medical malpractice claims, at least in the US where it has been advised. And it has a 20 to 50% of rate of error for detecting early lung cancer. So imagine how important this is, and try to imagine it within the whole patient journey. This is something that is missed. Anna had some cough. She has a second degree relative. If there was some more information, patient information and education, this is caught as early as possible. So the earlier you catch something, of course, the more you can do for the patient. So this is a very important finding, and we're lucky to have, and the resident is happy to have, a clinical decision support tool that can aid further his suspicion. And otherwise, it would be one of these 20 to 50% missed opportunities of detecting early in the course of the disease that lung cancer. And of course, one of the most common regions for missing those opportunities are paramediastinal, right, the cardiac and perihelial regions. Why? Because a lot of organs are blocking the view or the easy view of the lung tissue. So it's very normal. And this also is creating some sort of a continuous education, because he's reading this information, who he can absorb and use for his next patient cases. He must watch out for these three particular regions every time he watches and he sees and he evaluates an X-ray. So we're in every sense, he's gaining some information here. But the important is our patient, Anna. And of course, he decides next day, he talks about these findings with his head resident and the head resident and the director and the whole team. And of course, due to the severity, the localization of the region of the mass, as we saw, and also the history of cough and of his relative, they decide to order CT to evaluate further if there are any additional masses. And yes, indeed, they find another mass at the upper lobe, left lobe of the lung. Sorry, I missed an L here, upper lobe of the lung. So what should be the next sensible step? That Anna, they inform all of this to Anna's primary care physician and also the chest specialist, and they decide to talk to Anna and her family about this grave diagnosis, which always generates so much anxiety in patients and so much stress. So what happens is they need to book an appointment with the oncologist. But before that, Dr. Lee and the oncologist really want to, and the pulmonologist really want to inform Anna of her condition. What could happen? What are the possible complications? What are what's the possibility of recovering? What does it mean to have this diagnosis, which is so burdensome? And they don't want Anna to go into Google and find information that it's always very scary. You always find terrible things at the top of the results. So you want something to be informed and evidence-based so that you can really convey that trust to your patient. So they log into Clinical Key and find filter by patient education. They type, in this case, non-small cell lung cancer, because it's a highest possibility of having a type of cancer, but they could have typed cancer in general of lung cancer. And they're presented with some very easy to understand brochures and handouts that you can print out and hand to Anna and her family, so she has more information about her condition. Also, before she leaves the office, Dr. Lee wants Anna to see the oncology nurse. This is a very highly specialized nurse that is specially dedicated to seeing patients with oncology oncologic diagnosis, and to give her the best patient experience possible. So advice of this meeting that is going to happen between Anna and the nurse Damia. She's seen a lot of patients lately, but mostly breast cancer patients, and she has not refreshed her knowledge lately on lung cancer. So she logs into her cell phone. She's not at home. She's at the hospital. She doesn't have a station to work in. So she logs into her cell phone. She clicks into nursing, clinical key for nursing, and she goes, she types lung cancer and goes into type of content, which is mostly evidence-based nursing monograph. And you can see some screenshots of the look and feel of clinical key nursing or any type of clinical key in the cell phone. And she reads through the different sections and just getting up to speed on what's happening, what's the latest information, what's important, what is it going to be important for her patient that she knows and be aware of, so that again, they reduce the rate of complications due to any unawareness of the condition, and to increase, of course, treatment adherence. The more informed the patient is, the better prepared they are to face any complications and adverse reactions from the treatment. So, of course, they also our clinicians also need support regarding adverse reactions, particularly with such complex and burdening treatments as chemotherapy or radiotherapy, for example. So you can check the adverse reactions report frequently, also in clinical key for nursing, and she'll go back and forth through this clinical decision support tool to support Anna during her treatment. So what happens next, of course, is you must have a further analysis of the mass, the lung mass. So Anna undergoes surgery, they remove the mass, and the mass is sent to be analyzed by a pathologist. Okay, can you hear clearly, Jade? There's a comment in the chat.
Yes, we can hear you very well.
Okay, thank you. Okay, thank you. So the pathologist receives the biopsy specimen and processes it for imatoxylin eosin, the first step in the histopathological analysis. And the images he sees resemble something that has an SNR growth pattern. So it could be an adenocarcinoma, part of the non-small cell lung cancers. It's the highest rate of type there is, but there are also other additional diagnoses that could be also resembling an adenocarcinoma, and he wants to make sure he's not confusing this with anything else. So he goes into expert path and types adenocarcinoma and filters again by thoracic to refine the search results. Because if you are probably aware that pathologists have a great responsibility in the ultimate decision that will lead and guide the treatment of the patient. So this is a huge responsibility for the pathology services, especially in when you're diagnosing oncology. Of course, you need to do precisely the staging of the disease to be able to inform this to the oncologist and provide the correct and best treatment possible. So you can see the way they carry on their shoulders to provide an informed, evidence-based decision that can impact heavily on the patient. So expert path allows for comparisons to be made when you choose between some diagnosis, in this case adenoid cystic carcinoma or adenocarcinoma. He checks the stains, he reviews and compares the gross imaging, and even goes into the text to see the macroscopic, microscopic details, and to then request some further stains that would allow for that decision or that choosing to be made in a sensible and evidence-based way. So what happens next is immunoquery, which is another clinical decision support tool, which contains, it solely focuses on immunostaining to differentiate very clearly between conditions. And it provides in a very informed way, once you choose the conditions you want to compare, although this is tiny, but whoever wants to see any of these tools in action, please contact us, contact Jade, contact Natasha, contact Chris, and Laís and myself, and we can walk you through in detail, because this is in any of the solutions. This is not the purpose today, is to show you how that patient can flow through the different services, and the different services can use support, clinical decision support tools to support their decisions and make informed decisions. So once you have the panel of the immunostains, which are here on the left, you can see which ones differentiate better than the others. You request those stains, and then you can be certain that the diagnosis is one or the other. So finally, once you have the diagnosis made, you have you have spoken to your patient about the final diagnosis, and of course, what's the prognosis of that diagnosis, and you inform your patient well what's going to happen. Sorry, maybe here. What's going to happen, then you go, the oncologist logs into clinical path to devise or to create that consented treatment with your patient, because patient consent and the opinions of the patient and patient preferences are extremely important, especially when you're dealing with a complex condition and diagnosis as cancer. So you log into clinical path and you start typing in all the information you have obtained from the pathologist to understand which stage your patient is in, what is the type of cancer, what if it's metastasized or not, nodules, etc. So you just follow the very easy to follow path, this clinical path, to understand which of the treatments you want to choose. And you can choose either a treatment that is on pathway or out of a pathway. So even if in your setting, in your hospital, you're not following strictly the NCCN guidelines, you can still devise another type of treatments, because clinical path will obtain from the literature what has been reported in different phase 3 trials, for example, and you are able to devise also your treatment based on your best knowledge and the patient preferences, as I said. But in this case, we chose an NCCN guideline and proposed a treatment based on cisplatin and vinorelbine for 28-day cycles. So this is how, as if you remember Laís's journey, the quality and safety journey she presented, and she said this, you're going to see throughout the patient journey where what I have just shown, where do they fit within this framework or this journey, right? So we can see there's a staff and education skills. We show you with clinical key for nursing. We show you how care of patients is supported, highly supported, with clinical decision support such as StatDX, Expert Path, Immunoquery, Clinical Path. And we also reminded you of how patient participation and involvement is extremely important, and how with the informed consents and patient engagement and patient information, you are involving the patient within that journey. Also in clinical path, when you decide, well, this treatment will generate these adverse events, would you rather have a different treatment to see if that adverse events are more tolerable? So you can see, hopefully clearly, we have shown you how everything is integrated into the quality and safety journey through clinical decision support, information management. Everything is supported by information and by technology, and how the evidence merges with technology to provide the clinical decision support. So before we leave and we jump into any questions, we wanted to go back to reflect to the first question, that Laís made on the quality and patient safety journey, of which were the strengths in your hospitals. So now, after seeing this, which of the pillars you think have opportunities for improvement after seeing this journey very fast? And I apologize because I was rushing through time, otherwise I would stay here talking forever. So where do you think your hospital can definitely improve? Is it in community management, making the community aware of how to prevent development of conditions, particularly the non-communicable diseases, chronic ones that are heavy burdening on population? If you see that information management is still lacking, that you can add more decision support. The staff and education skills, they were really strong already. Do you see any possibilities to improve even further due to accessibility of information, for example, through different platforms? Also about the care of patients, do you see that this is something where you could be supported by patient engagement, patient information, also the possibility to involve the patient preferences into their own care design, and the research and continuous improvement? How can we use these tools to provide us with information that we can then further integrate into our processes of improvement? So I don't know how further we are into the answers. So we'll allow you a little bit more time. We're 40%, that's great. We'll give you a little bit more seconds. And of course, you can start thinking of any questions you wanted to ask Laís and myself. Any comments you might have, any doubts that you might want resolved, any contacts that you want to make, and we can explore further how we could support your own settings in introducing new and innovative ideas of doing things, and how we can support you in that improvement journey of improving quality and safety. We're more than happy to be responding. Okay, so let's see the results. And this is great because, again, staff and education skills seems like a good place to start making changes and improvements, or potential improvements. And this shows that definitely there's room for improvement, and as long as we have the information and we have the support, we're able to create those changes and make those changes. Laís, would you have any comments on this very interesting results that we had from our audience?
Absolutely. So it's very interesting to see that numbers 1, 2, and 3 are actually the strengths that were listed on the first poll. So we see that even though it's a strength, we also have opportunities for improvement, which is fantastic, because that's how continuous improvement should be, right? We need to keep making sure that we always improve, even our strengths have to be improved as well. So the results are not surprising, and they're very good to see that the audience is really also aligned with us on the continuous improvement efforts, which is the first step to improve quality and safety.
Yes, it is indeed. So I think we have some time for questions. We really skidded through this quite fast. Chris, is there anything you want us to review or to reinforce?
Sure. Well, thank you, by the way. Fantastic presentation. As an ex-oncology nurse myself, I found it really interesting.
I should have had your image there. Your picture, you should have sent in your picture and I would have pictured you there. Come on.
Yeah, I knew you would have done that, and that's why I held back. So, but I do have some great questions for you, though. So one question that's been raised is, how do we ensure clinicians, especially young doctors who don't have experience, don't miss diagnostic findings?
I'll do my part, and then I'm sure Laís will have some comments too, because
Okay.
if you don't are aware of, Laís is an expert in Joint Commission International. She's the daughter of a surveyor, and also she's been heavily involved with JC for a long time. So she knows a lot about procedures and
Okay.
how to make them run. But I can tell you that for me, that the best approach is to participate as much as possible. Do not limit your practice hours to the official practice hours you have by curricula. If you have the chance and you have the time, expose yourselves as much as possible to cases. Reading, I'm sure the books will have almost everything, but there's nothing like the true patient experience. And there are a lot of variants that are not captured in the literature, unfortunately, because they're rare cases. So rare cases you can only capture either by experience, by offering yourself to do more shifts, to do more weekends, just sitting there together with a experienced radiologist and to ask questions. And then also in the literature, you can start by reviewing case studies. So case reports are isolated cases of studies that are novel because of anything, of the presentation, of the treatment, of the diagnosis. So they're just at the very base of the pyramid, evidence-based pyramid. And they're creating that idea of this is something new. We don't know what it is. It might be important, it might not. But then if it is, it will lead to a phase 3 trial eventually with a particular treatment and a particular set of diagnoses. So expose yourselves to a lot of information, a lot of cases from your own hospital. If you can do now with COVID, everything is a little bit restricted, moving, but if you can do practices somewhere else in other hospitals that are, for example, I practice in hospitals that were in a very conflicting area of Colombia. So we received a lot of patients in very weird situations and very extreme situations. And that really gave me a lot of information that I then took to the US. And I had more knowledge than the residents. But it was just a question of chance because I was there in that place. So try to expose yourselves to as much difficult, challenging cases as possible. Support that knowledge with case studies from literature. Go to Clinical Key, go to PubMed, search for case studies in radiology or in your own area of expertise, oncology, whatever you're going into. And then create that culture of reviewing, of researching, so that you can support that quality and patient safety journey. But definitely practice is what is going to make perfect. It's very difficult to find something that you have never seen. It's very challenging. So, and you might not remember everything that you learned in the book. So practice makes perfect, and then support it with evidence from case reports, at least for the challenging cases, the strange ones, and then clinical decision support. Ask yourself questions. Is this normal? Is this what I'm seeing? Go to your clinical decision support tools to reinforce that idea. That would be my suggestion. Laís.
Right.
That was great. I mean, it was fantastic. The only small comment that I would add is don't be shy to use technology in your favor, because we see many times that there is still that barrier of using technology to reach all the knowledge that Ximena just mentioned. Don't be shy to use it, and make sure that you're searching it in trustworthy sources.
In the right places,
Do not
right.
use Wikipedia. Do not use Wikipedia. But yeah, just don't be shy to use the technology that has relevant information that you can get some more knowledge from.
Right. Thanks a lot, Laís and Ximena. We have 3 questions here, and more are coming as I go on. One question is, what's the role of nurses in cancer care and any changes post-COVID?
Yeah, I can take that one and then pass it over to Ximena as well to make some comments. But I think we have to start by saying that the role of nursing in general is very different from region to region, from country to country. So that is known. right? In some countries, nurses have more responsibilities on their plate. In others, they share more responsibilities with other disciplines as well. But the one thing that does not change at all is the need for continuous education and continuous improvement of skills, and also the ability to use decision support on their benefit. So that is the main thing that puts us all together, I would say, in oncology and also outside oncology nursing, which is improvement of skills and decision support as well. Now, about the COVID comment, I recently read that, and I also saw that in many different countries happening, some oncology nurses were relocated to COVID-19 centers to also care for suspected or confirmed cases of patients with COVID, and due to the shortage of human resources. And that's not new, right, for anyone. We know that the shortage of oncology nurses affects patient care and cancer care more specifically, and that's all over the literature. So that further relocation also had that effect. And of course, because of that relocation, we also have an increased risk for cancer patients in their shifts as it rotates with the normal cancer care routine and also COVID-19 patients. So we really saw also the need for the oncology nurses to bring, to speed up their own education about, for example, PPE use and all the different guidance that we got for COVID, because they were also caring for such a vulnerable population, an immunocompromised population. So we saw that as well. So in addition to the skills that were already needed to be improved, there was an extra burden during the COVID-19 of accelerating that skills learning so they could apply to care and increase the patient safety in their units. Ximena, any thoughts on that?
I agree completely that the learning curve has been incredibly steep because of the high demand of staff, right? And nursing, although the roles do change, as Laís says, from country to country, what is also undeniable is the importance of nursing in the detection of early changes in the patient. So they're an incredibly strong player within the whole system because they're the ones in continuous contact with the patient. So if a patient is hospitalized due to COVID or anything else, and there's a risk of nosocomial infections, the nurse will probably be the first one to see that change and to alert the clinician to make changes in the treatment. In some countries, nurses are allowed to treat patients too. And everyone is now being called to be the best they can be because of the demands of beds and demands of staff in hospitals. So for me, one of the biggest roles nurses can play is the research part. I'm a huge advocate of researching in general, but nurses have that very special place that none of us have in the hospital, which is the continuous surveillance of the patients. So due to that, they collect a lot of data and a lot of information that has to be fed back to systems in order to make those changes and improvements. So for me, they're a key player, not only due to COVID, but all the time in every single setting of the hospital, since the triage, incredibly important nursing role that plays there, to hospitalization, to ambulatory care, the continuous care of the patient outside. So I wouldn't see a world at all without the incredibly important nursing staff that we have. It would be impossible. Doctors would be at loss without nursing. So it's more important than maybe some countries think they are. It's not just a doer, it's actually one of the creators of quality and safety in the patient. So incredibly important figure to have in hospitals.
Right. There's a lot of questions coming in here, so I'm just going to have to pick a few to make the most of the time. And one is, and I think this would be perfect for you, Laís, it's how would culture be incorporated into the quality of cancer patient journey?
Thank you, Chris. And thank you, Ryan, for asking that question. I absolutely love this question, especially because culture is it's basically the line of the journey that's culture, right? It's the underlying power of the quality and patient safety journey. It's there. The whole point of the quality and patient safety journey is to improve the culture of safety, is to make sure that everyone in the hospital, everyone that is involved in patient care and involved in the environment, in the system, can also work towards a culture of safety. And how you do that? This is one of the ways of doing that, is by making sure that you are empowering people. First of all, that they understand what quality and safety means, right? And that everyone is part of quality and safety. No matter who you are in the organization, what your role is, if you are there, you are part of quality and safety efforts, and you're part of that culture. So the breakdown that we have, the 6 pillars, the idea is really to make sure how can we create tools and how can we incorporate the culture into the day-to-day life. So it walks people through the main pillars and the main ideas on how evidence can also support the culture of safety, right? And it's a very practical approach to the theory of culture. So step by step, by introducing evidence into your day-to-day life, empowering people with the knowledge and technology. And of course, it's the people part, right? We mentioned that the system is about people, process, knowledge, and technology, and all together they work to improve the culture of safety. But thank you very much for asking that question. That's a great question. Not sure, Ximena, if you have any comments to add to that?
Not for now. I was just reflecting on the fact that that I didn't answer correctly about the oncology question. So I'm going to post some sites that you can go. I'm sorry, about not answering directly. So so I apologize for this because it was specifically directed towards nursing in oncology. So I'll send some links via the chat anyway. I'm sorry. But no, I agree with everything that you've said, Laís. Nothing to add to this.
Right. Look, if it's okay, someone did ask a question here that, as a host, I thought I'd like to answer this as well, because I thought it was a really good question. It was about how to communicate with a patient who is terminally ill. Now, interestingly, I mentioned before, many of you know me as the product sales manager for Elsevier, but I was an oncology nurse, and I actually have had a father who passed away from cancer, and my mother is now battling cancer for the 2nd time. So I've been in many meetings with doctors, and many times I've seen my parents walk away very frustrated with the engagement. And now I would say, having been exposed to oncology from both sides, that the number one thing is to listen. I know we're so busy, but to be able to listen to your patients and identify what's really concerning to them. Sometimes it's more than just the medical condition. They may have other stresses, and to be able to provide that holistic care. That's from my side. I just wanted to say thank you again for a great presentation. It's really good to see a presentation from Ximena and Laís that is so aligned with our mission at Elsevier, which is to improve patient outcomes. So I think this is the perfect Thursday evening. So thank you, everyone. And if you have any feedback,
thank you so much.
please share via the link below. Sorry.
Sorry, and all the questions that came through, maybe we can gather them, I'm sure, because and we can probably offer some additional support to some of the questions, like research involving cancer. So there are some questions that are so interesting that maybe we can trace back and respond directly, if you don't mind, Chris. It would be great to have the chance not to leave them an answer, because they're so very straight to the point. Yep.
Dr. Ximena, sure. So thanks for offering. First of all, thank you so much to you and Laís for all the insights that you shared. Great presentation from the two of you. Thank you very much. And also, it's very generous of you to offer the questions that to answer the questions that we couldn't cover in this session. I'd like to assure the audience that we're very sorry we couldn't cover all the questions, but all the unanswered questions, we'll forward them to Dr. Ximena and Laís. And once they send us their feedback, we will forward them to all the attendees. Finally, thank you very much for attending our session today. Should you have any further feedback, you can always write to Jade. Her email is in the invite that you would have received. You will also receive a thank you email for attending this session. So there will be a link in the thank you email for you to provide feedback, or you can send additional questions by just replying to the thank you email, and Jade and I will look into it. Finally, some of you may be interested in getting an e-certificate for attending this session. There will be a link in the thank you email from where you can generate your e-certificate. Once again, thank you so much, Dr. Ximena. Thank you so much, Laís, and thanks, Chris, for managing the session. Everyone, I'm very, very grateful for all of you to be here. Thank you and have a good evening. Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Thank you.